Welcome, everybody, to this session on mental health care for autistic people. I am a researcher at the Mental Health Policy Research Unit, and together with Sophia, who unfortunately wasn't able to be with us today, have been co-leading a research project on this topic for about a year now. And we co-organized this session that brings together presentations on policy and research in this field, findings from two systematic reviews that we've been conducting, and lived experience perspectives, as well as a panel discussion with wonderful panelists presenting sort of various perspectives. Just to note that in the interest of time, there won't be time for questions after each presentation, but as I said, at the end there is a panel discussion for questions from the audience. We are kicking off this session with Dr. Lorcan Kenny. So without further ado, Lorcan, the stage is yours, and thank you very much.
Thanks. So my name is Lorcan Kenny, and I'm the National Research Lead in the National Autism Programme at NHS England. And I'm going to give a little bit of a general background about myself, about our programme at NHS England, and then I'm going to talk about one document that is currently in draft form that was influenced by the systematic review that Tamara and Sophia presented to us at NHS England. So first of all, a little bit of a background on me. I first worked as a research assistant within the psychology department of University of Nottingham before becoming a research and communications officer at the Centre for Research in Autism and Education in the UCL Institute of Education, where I stayed to do a PhD focusing on daily living skills in autistic teenagers, and then became the research network lead at Autistica before becoming the head of research at Autistica, where I headed up the research governance about research grants that we gave at Autistica for that period, although it was during COVID, so we did not give out that many grants. And then I became the national research lead for autism at NHS England, which is where I am still working. And the programme in NHS England is, so for people who don't understand, it's not that straightforward to understand the role of NHS England. It is one of the arm's length bodies of the Department of Health and Social Care in England. So we give guidance out to local systems which they can choose to follow or not follow, because with the introduction, as I'll talk a little bit more about the new Health and Care Act, the legislative context of how health and social care is delivered in England has changed quite considerably in recent years, where there's quite a lot more local autonomy for making choice about how you run your health and social care service. So national policy often comes in the form of guidance rather than mandatory policy, which I'll explain a little bit more about. So to give some of the background about the context that we're working within, we're in a relatively unique position in that we have a condition-specific piece of legislation in the Autism Act, which is an act about the delivery of services for autistic adults. And that act is particularly powerful and clever in the way that it was brought about, in that it specifies that there should always be an autism strategy, and that should be kept under review and updated as needed. And it also states that there should always be statutory guidance setting out the responsibility of NHS organisations and local authorities for the delivery of services to autistic adults, which should also be updated as needed. And so one thing that's a little bit confusing about this is we had a number of editions of autism strategy for adults, but the most recent one made it an all-age strategy, so it's for children, young people and adults. We still have the version of the statutory guidance that predates the last strategy. So we have a strategy that is for all ages, and we have statutory guidance that is specific to adults. So we're in this kind of slightly in-between stage. The Department of Health and Social Care are working on updating those statutory guidance. So we hope, but we haven't had confirmation yet, that the next version of the statutory guidance will be all age. So that means it will set out in much clearer terms what NHS organisations must do and what local authorities must do in order to fulfil the duties in the Act, but also what they should do. So what they should consider doing but are not bound by a piece of legislation to do. So the context of those is quite important. Some other context is that in 2015 there was a national plan and a national service model that were published, which are known as Building the Right Support, which is about improving the quality of mental health inpatient care for autistic people and people with a learning disability. And the other relevant policy context when it comes to the use of evidence in policy is that there are 3 different guidelines that dictate how clinical services should be run from NICE about autistic people's care. So the really driving force in the national programme that I work within is the publication of the NHS long-term plan in 2019, which for the first time included autism as a clinical priority. So this was a really big shift in NHS England prioritising the need to improve care for autistic people. And it sets out that we should be doing more to ensure that all people with a learning disability, autism or both, can live happier, healthier and longer lives. And specifically it sets out ambitions around improving autism assessment services, reducing health inequality and reducing reliance on and the quality of inpatient mental health care, which is what I'll talk a little bit more about in this talk. And also, as I mentioned, the Health and Care Act has changed the commissioning landscape, whereby the role of NHS England is to put out these kind of guidance documents that local areas can decide if they make sense to apply exactly as they are, or whether they make some tweaks based on the local context before applying something. So some things that we have done since that, so the NHS long-term plan is what was the kind of the impetus to form a national autism team at NHS England for the first time. And there's a couple of things that we kind of took on quite early on, which was making sure that we didn't fall into this trap that policy often does of saying in 5 years' time we will have achieved X, or in 10 years' time the following will have happened, but actually not putting in place the infrastructure that's required to check that that is actually the case. So one of the first things that we looked at was publishing the Autistic People's Healthcare Information Strategy for England, which is a strategy that sets out how we can better use data that's already routinely collected about the health of autistic people and about the healthcare that they receive, so that we can have a look at whether the policies that we're putting in place are having the impact that we want them to have on the outcomes that we're interested in changing as a result of those policies. So as a result of that strategy, we have 2 dashboards, data dashboards, that are available to people working in NHS or local authority services, where they can have a look at how they're performing relative to other parts of the country in relation to, for example, their assessment waiting lists, access to physical health care, information about the population of autistic people, because one of the things that we often notice is that when you say commission enough services for the size of the population in your area, people actually don't have very good data to tell how many autistic people are living in their area, and so that becomes quite challenging for them to do. So these are some of the things that we're trying to improve. And then the reason that I got involved in NHS England specifically was that in 2022 we published a 5-year autism research strategy for NHS England. So in addition to having data to be able to tell if we're making a difference, we also needed to make sure that the policies that we're making are based on and informed by the best current evidence available to us. And so this strategy set out some ambitions around determining which areas of the NHS are based on reliable evidence and which are not, because plenty of things that happen in the NHS at the moment are not evidence-based or evidence-informed. Ensure a better fit between the evidence that's produced and the evidence gaps, so that's us having conversations with the NIHR, for example, and other funders saying these are the gaps that we really need filled in order to fulfill our policy ambitions. To facilitate the use of the best current evidence when making decisions about autism services. So that's when people are writing policies, coming to us and saying, can you check if what we've said in here is based on evidence, or do you have any modifications, suggested modifications to the document we're working on? And also to help improve the evaluation and effectiveness of policy. So often somebody makes a policy and they kind of assume, because we made this policy to improve this thing, now we've made the policy, we'll just assume the thing gets improved. Whereas actually an evaluation is required, and quite often, just as you would have in intervention science where you do an intervention with the anticipation it will produce a particular effect, sometimes you test it and find out it has the exact opposite effect, or no effect at all. And the same is true of policy. You can put policy out with the best of intentions and then evaluate it and determine that it's making no difference and costing lots of money, or that it's having the opposite effect to what you intended. So it's really important that policy is also evaluated. So now I'm going to talk just briefly about a document that we're working on at the moment. So as I said, this is in draft form and currently under review by an expert reference group. So it could be subject to change based on those, that feedback. So this is guidance that we've set out, dividing mental health care into 4 different levels of stepped care that are demarcated by how acute the need of the patients that are being treated by these particular services are. And our reason for setting out this particular model is to really highlight to people who are commissioning and running services that good mental health provision for autistic people is not provided solely by services that were commissioned specifically for autistic people. So quite often people think of autism services as autism diagnostic services and acute inpatient mental health services that are specifically for autistic people, and they kind of forget that there are mental health needs that exist along that continuum the whole way. So we talk about mental health needs of autistic people being delivered by services that are focused on level 1, which we call staying well in the community, level 2, which is planned mental health care, which could be primary or secondary planned mental health care. Number 3 is crisis, intensive or unscheduled mental health care, and number 4 is inpatient mental health care. And in this document, we set out a number of principles, and these principles are listed here, which is that all services across each of these levels should be accessible and acceptable to autistic adults, that these services support access to meaningful activity, so it's not just about therapeutic input for the particular mental health need, that they facilitate timely access to autism assessment when that is clinically indicated, and that they assess and proportionately manage risk, monitor and minimize the use of restrictive practices, support transitions to be cohesive, and to do that they should have a local commissioning strategy that is informed by national and local data, and obviously you're going to need to have a well-trained workforce to do that. So I'll answer more questions about this in the session if people have any, but I'll leave it there for now.
Hi everyone, so my name is Richard Pender. I'm a clinical psychologist. I've worked for about 6 years in autism services in the NHS, also an autism researcher at UCL and a member of the working group for the review that Tamara and Sophia will be presenting. And I'm going to be speaking for 10 minutes on an overview of some of the research on mental health care for autistic people. And it's a broad and active field, so I will need to just select a few key ideas that I think are relevant. So I'd like to start by speaking to the idea of an autism mental health crisis. And this is a phrase that was used by Will Mandy in an editorial in the journal Autism last year. And this refers to the observation that autistic people are known to have a higher chance of developing a range of mental health conditions, but also, crucially, additionally, a lower chance of receiving effective help. So in this talk, I'll be speaking to the high rates of mental health conditions that we know that autistic people experience, and also to the barriers and limitations in services that autistic people themselves have described. So to start, there was a meta-analysis published in 2019 in The Lancet that showed that consistently and across a range of mental health conditions, there was a higher prevalence for autistic people than in the general population, including anxiety conditions, depression, bipolar, schizophrenia spectrum conditions, OCD, and sleep-wake conditions. And looking to the wider literature as well, we know that there's increasing evidence for increased rates also of trauma and victimization, self-harm and suicide, of reduced quality of life, and premature mortality. So a key objective for autism research needs to be to really understand the reasons for the increased rates of mental health conditions and to use that knowledge to actually address the situation. And it's important that we also think about how we understand this and how we frame this, because research in this area has often been guided by what we might call a pathology model shown in this diagram here. And the logic of this is that the increased rates of mental health conditions must be the consequence of some autism-related characteristic that the person has. And those characteristics have often been problematically conceptualized as impairments or deficits, hence calling this a pathology model. And within this approach, research has looked at individual differences in things like IQ, language, functioning, number and types of autistic traits, and so on, and tried to explore how those might predict mental health outcomes. But where relationships have been found, they've been small, they've been inconsistent, and they actually lack applicability into how we can really deliver better support for people. It's an artificial way of thinking, in my view, to just look at individuals in isolation and to locate problems entirely within individuals. And it goes against, to my mind, the neurodiversity paradigm and the way that autistic people themselves speak about their mental health experiences. So what I propose is a preferable way of thinking about this is through the idea of person-environment fit. And in this model, we think of autism more as a cognitive and sensory processing style, and mental health outcomes as being influenced by the interaction between a person's processing style and the extent to which the environment is suited to that. For example, if someone has sensory sensitivities, it's quite intuitive for us to understand that the environment plays a big role as to whether somebody's going to feel overwhelmed or feel comfortable at a given situation. And there's a wealth of evidence that links autism masking to a range of negative mental health outcomes. So autism masking is when an autistic person needs to hide or camouflage some of their natural communication style in order to kind of get by in a neurotypical majority world. And so masking happens within a social context. People mask more frequently and extensively when the social context feels unsafe or threatening or is poorly suited to that person's needs. So if we're going to understand risk factors like masking and sensory sensitivities and the other things that people explore, we need research to take account of the environmental context that people are actually in. And that will produce research, in my opinion, that's more compelling and consistent, but also is applicable to developing better support and treatment, because we can intervene on the in-person environment fit to support people better. And when autistic people themselves have spoken about mental health services and the state of the support that they've received, it's been mixed or negative. And Janina Breda and colleagues published a systematic review last year of qualitative research in this area, so interviews with autistic people and their families and with clinicians as well. And this quote from the review I feel is worth highlighting. So, our findings show that currently mental health services do not adequately support autistic adults and can even cause additional harm. And there were three overarching themes that the authors highlighted about barriers to care. One was a lonely, difficult service experience. So people experience services as inaccessible and at times unwilling to meet their needs. They spoke about feeling like no one was on their side and that there were barriers every step of the way, from knowing how to get support in the first place to then encountering clinicians who seem to lack awareness or have stereotyped attitudes, and also needing to adapt themselves to non-autistic norms of service delivery. And they spoke about finding this at times was actively harmful. So what people thought might help with this is that services need to be flexible. Clinicians need to understand autism. They need to understand the lived experience of autistic people and how autistic people experience their mental health and talk about their mental health, and crucially use that to adapt the way that services are delivered, adapting communication style, supporting people to express themselves, and adapting physical and sensory environments as well. And they also need to develop trusting and positive relationships with people by treating people as experts on their own experience and empowering them to take an active role in their own care. And looking to the broader literature on barriers to receiving mental health care that autistic people have described, another systematic review found that the most consistent theme across studies was a lack of professional knowledge and awareness. And one illustration of this, Silke Lipinski and colleagues last year published a study of a survey with therapists asking them about their confidence and knowledge of a range of conditions, and they rated their knowledge and confidence of autism lowest of all the conditions that was on the survey, but also had a high desire and willingness for training that had clearly not been available. Other barriers include long waiting lists and complex systems that are difficult to navigate, and at times people having inappropriately rejected referrals from mental health services based on a lack of understanding of autistic people's mental health, and being bounced around between different services because of a lack of clarity of pathways and a central place to coordinate care. To say something briefly on psychological therapies, I think going into the evidence base here in any depth would be a much longer talk. So I'll just pick one example, which is a recent network meta-analysis by Audrey Linden and colleagues. And they looked at controlled trials in this area, and they concluded that, yes, of course, autistic people should have the same access to psychological therapies that non-autistic people do. But also psychological therapies need to be adapted in line with person-centred care. And the evidence we do have shows that adapted psychological therapies do work better than when they're not adapted. Most of the studies in this area have looked at CBT, cognitive behavioural therapy, but there is emerging evidence for a range of other therapy models, including third-wave therapies. I think the really important thing in this area, though, is about where we go next. And I would suggest that we need to think about better and improved evidence for adapted therapies. The meta-analysis that I mentioned highlighted that there were biased studies and limited studies in this area, and we need better quality evidence. And I suggest that we need that at two levels. Firstly, about autism-friendly delivery, so making things adapted on the level of communication and removing barriers and making them accessible, but also going deeper into developing autism-specific models of mental health care and treatment by drawing on the evidence base from the person-environment fit literature, and also by co-producing new models of treatment and testing them that reflect better autistic people's mental health experiences, including things like masking and burnout. And adapting oneself to a neurotypical majority world. So to briefly summarise, autistic people are likely to experience higher rates of a range of mental health conditions. I suggest that we should not understand that through a pathology model, but rather through a person-environment fit model. People have described having negative experiences of receiving mental health care. And similarly, adapted psychological therapies in places have shown less effectiveness than for non-autistic people, but we know that adapted therapies do better, and one important future direction will be to build better psychological therapies that are adapted by using environmental person interaction evidence and also by co-producing therapies with autistic people themselves that better reflect and account for the autism-specific mental health experiences that autistic people have. And some of those things I think will help towards addressing the autism mental health crisis. I've gone over my time already a little bit, so that's me. Thanks for listening.
Okay, so I don't know if I mentioned my name, but my name is Tamara, and together with my colleague Sophia, we are currently co-leading a project about approaches to improve mental health care for autistic people. And today, I will share our findings from two systematic reviews, collecting and summarizing evidence from existing research, one that relates to autistic adults and the other one to autistic children and young people. We have been working closely with a larger working group consisting of clinicians, researchers, and people with lived experience, so I'm presenting on behalf of this larger working group today. So this presentation reports independent research commissioned and funded by the National Institute for Health and Care Research Policy Research Program, conducted by the NIHR Mental Health Policy Research Unit. The views expressed are solely those of the authors. This is just a very quick outline of my presentation today. Briefly to mention that I will describe people on the autism spectrum as autistic, so using first-person language, but I understand that some people may prefer other terms as well. So Right. Linking to some of the previous presentations as well, although autistic people are likely to experience mental health difficulties, they're actually less likely to receive the right support to help them manage these difficulties. So it's particularly important to identify and explore ways that have been used in mental health services to better meet the needs of autistic people and improve their mental health. This concern was raised by members of our team with lived experience and then also gained support from policy makers. To inform a response, we conducted 2 systematic reviews to identify and examine any strategies or ways that have been used, that have been implemented to improve mental health care for autistic people. These strategies included bespoke mental health interventions, so treatments specifically developed for autistic people, standard mental health interventions adapted, tailored to the needs of autistic people, and adaptations in how mental health services are provided, including ways to identify autism in mental health services. We aimed to address the following research questions. Besides finding out what these strategies are, we wanted to know whether these strategies are feasible, whether they are acceptable, and are they effective? So do they improve mental health of autistic people? So we carefully looked through various sources of information. We systematically searched 3 electronic databases. We also searched for additional studies and eligible unpublished studies through preprint servers and a call for evidence from experts. In terms of inclusion criteria for the systematic reviews, we were interested in studies that included adults and/or children and young people with an autism diagnosis, or who suspected they were autistic, or who were identified by clinicians as potentially autistic. We were also interested in studies that explored views from carers and clinicians that provided mental health care to autistic people. We included any strategy that related to mental health care for autistic people, but it needed to be delivered in mental health services or mental health care in primary care. Studies had to provide any relevant information, outcomes that were linked to acceptability. So, for example, were people satisfied with the treatment? What was their experience, whether it was qualitative or quantitative data? Feasibility, so did the people complete the treatment? Did they attend the intervention? Or effectiveness of these strategies, so did they help to reduce mental health difficulties such as anxiety and depression? So after screening for eligible papers, we extracted and tabulated all relevant information. But because of how different the studies that we found were to each other, we went with a narrative approach to combining, summarizing, and explaining the findings. But for the review on autistic children and young people, we actually identified a scope to conduct a meta-analysis which focused on cognitive behavior therapy-based interventions for anxiety. We assessed the quality of the papers as well as the strength of the evidence contributing to effectiveness outcomes. So this diagram shows the process of searching and selecting relevant studies. In brackets, you can see the number of records or studies at each stage. In total, we identified 30 studies that met our criteria for the review on adults and 58 for the review of children and young people. These 2 reviews share the same 13 studies, which reported on combined outcomes for adults and children and young people, so they were relevant for both reviews. The findings that I will present are based on these included studies. But firstly, a short overview of these included studies. So you can see that not all included studies contributed to findings related to acceptability or feasibility and effectiveness. Most participants were service users, whereas only a few studies reported on the views of mental health professionals. terms of study designs, for the review on adults, there were very few randomized controlled trials, sort of the most reliable type of study for determining effectiveness, right? And most frequently here, studies were before and after comparisons. This was different in the review for children and young people, where actually the majority of studies were randomized controlled trials, but still there were many studies that were before and after comparisons. When assessing the quality of the studies, studies were of moderate to high quality, meaning that they were well done. Now, next to assessing quality of papers, we conducted a novel autism-inclusive research assessment. Members of our team with lived experience noticed that the way previous research studies have been done may not have been exactly inclusive or sensitive to the autistic experience. So a decision was made to try to capture this. A lived experience researcher developed 5 criteria based on existing literature and personal experience, and then these 5 criteria together were labeled as the Autism Inclusive Research Assessment. They were first piloted on a few studies and then later before assessing all studies with it. Taking into account studies across both reviews, we found that autistic people and their carers were rarely involved in the planning, carrying out, and write-up of the study. We also found that many studies did not report adapting the way they collect information from autistic people to increase participation, for example, offering nonverbal communication when collecting data. Close to a third of the studies reported that the relevant outcome measures are valid or adapted for use for autistic individuals. And additionally, some strategies or treatments tested in the studies seem to focus on changing autistic traits or behaviors, such as reducing repetitive behavior, rather than improving mental health. In terms of the overview of the strategies in the included studies, most strategies were mental health interventions or treatments that were adapted or developed specifically for the needs of autistic people. These were largely CBT-based, targeting anxiety. Mental health services were also adapted. This involved training mental health professionals to have more knowledge and skills about autism, making changes to the environment within the services, such as making sure that there's not too much noise around, or making some light adaptations and other more general adaptations, and finding ways to help people who may be autistic be identified in mental health services so that they can be referred to a specialist autism assessment and subsequently be able to receive the tailored support that they need. All right, for the findings bit of this presentation, I'm now going to present the findings of the systematic review that relates to autistic adults. This paper is currently under review, but you can access our preprint. So we were interested in how mental health services and interventions were specifically adapted to better meet the needs of autistic people. We put together all adaptations that were listed in the included studies and together with the help of people with lived experience, we grouped these together based on similarities and came up with 6 categories of adaptations, each having their own subcategories. It's important to note that we included all adaptations, regardless whether these were found to be helpful or easy to use. So some of these may not be suitable for everyone. 24 of the 30 studies in the adult review included some adaptations to services or interventions, and most studies tended to use several adaptations, so they were found to be relevant to multiple categories. Just going to give an overview of these categories now. Increasing knowledge and detection of autism. So this category mainly involved the use of screening tools to identify potentially autistic people, as well as training clinicians to provide better care. Then we have environmental adjustments. This involved changes to the physical environment, such as reducing noise and providing adjustable lighting, as well as providing sensory resources like a weighted blanket or ear defenders. Communication accommodations involved being clear, planning in advance, and using simple language and visual supports like pictures and videos. Accommodating individual differences involved identifying needs and preferences and tailoring treatment to these, as well as encouraging hobbies and special interests. Adaptation in relation to structure of the intervention involved changing of the duration or number of sessions, as well as involving family throughout the treatment. And finally, adaptations in relation to the content of the interventions involved simplifying the content, considering the role of autism in treatment, and introducing a variety of strategies and approaches. All in all, most studies, it's noticeable, included adaptations in relation to communication, whereas very few studies included adaptation related to the environment. In terms of our research question about acceptability and feasibility, we found that most bespoke and adapted mental health interventions were found to be acceptable and feasible, with the exception of two studies which tested, one tested a CBT intervention for OCD, and the other one tested a novel real-time stress management intervention delivered on a mobile platform. Service, just to mention this as well, in terms of specific adaptations and their feasibility and acceptability, so the use of visualization, so using a whiteboard during treatment, simple language, and a concrete and structured approach were perceived as helpful by participants, whereas the length and pacing of the session and use of predefined visuals received differing views, suggesting that a tailored approach to treatment may be particularly helpful. Now, service adaptations were also found to be acceptable and feasible. In particular, environmental adjustments, for example, in an inpatient ward, decorating it with a neutral color scheme, developing a sensory box as well, communication accommodations like hosting well-being groups, and the introduction of training to develop clinicians' knowledge of autism led to improvements in mental health care. Self-reported questionnaires were found to identify fairly accurately autistic adults from mental health services, so the use of these could be helpful in screening autism in these services and facilitate early identification. In terms of our research question looking at effectiveness, unfortunately, evidence on this was generally of low quality and thus inconclusive, given that most studies lacked a comparison group and had a small sample size. So we couldn't really determine the effectiveness of these strategies for the review on adults. Moving to the final section of this presentation, overall conclusions and bridging findings, some strengths of our reviews. So these are the first reviews that identified and explored strategies that have been implemented in mental health care for autistic people. These reviews are important because they cover what has been done overall and provide a comprehensive picture of the current situation in mental health services. They highlight a list of strategies and adaptations evaluated as acceptable and simple to implement, which may be helpful for tailoring treatments and services to the needs of autistic people. We had meaningful input from people with lived experience to ensure that what we did was appropriate and relevant. Next to these strengths, there are also several limitations, as usual. Looking at the included literature, there were lots of small studies reflecting individuals coming up with great ideas and then doing small studies to test them. So there is lack of few large studies that can provide high quality evidence that would actually shape practice. There were lots of studies that lacked a comparison group, preventing us from attributing any improvements in the outcomes to the intervention alone. And where there were comparisons in studies, they were not with a non-adapted intervention, meaning that hindering us from any conclusions on the effects of the adaptations. So we cannot unpick what the critical ingredients that create an impact of any treatment programs are, both for adults and children and young people. We found that there was lack of thorough description of how interventions were adapted and why in the included studies. Also, a high proportion of participants were white and male, neglecting underrepresented groups such as Black and and ethnic minorities and other gender identities. There was also an evident gap in the evidence for what works for autistic people with intellectual disability or autistic people with a severe long-term mental health difficulties. No tailored pharmacological interventions or prescription initiatives were found, regardless of the common use of psychotropic medication. And overall, input from autistic people and carers in the design, conduct, or write-up of the studies was lacking. Final slide. Both reviews demonstrated similar results regarding acceptability and feasibility of tailored interventions and services. However, the systematic review related to children and young people had much more trials than the review related to adults, providing stronger evidence of effectiveness. Many of the identified adaptations that are acceptable and feasible to implement in mental health care have also been prioritized by autistic adults in previous literature, showing that autistic people's priorities are being taken into account. However, we notice that some adaptations are more frequently used than others, so there is still more scope for improvement in service provision. In fact, many of the adaptations are quite simple and doable, meaning that they may not need much further evaluation. We know that autistic people differ in their support needs and the presentation of autistic traits. Primary research and a neurodivergence-informed approach to therapy, which challenges what quote-unquote normal is sensitive to diversity of minds and considers disability as a potential source of community and pride, is necessary to strike a balance between tailoring treatment to individual differences and adhering to evidence-based practice. These reviews can serve as platforms for a move towards national set of guidelines that then get tested in a small number of properly funded, co-produced research. I am finishing here. Two of our lived experience researchers wrote a commentary on the review findings, the review on adults. And in bold, I've highlighted the main points. So they wrote how accessing support is not straightforward for autistic adults, that many of the identified strategies are small and easy to do, and that they noticed a particular gap in the included studies that appeared to not include perspectives from autistic therapists, which has been shown to be quite transformative. This is just an extract from the full commentary. So thank you very much. And I give the stage now to Susie and Jenny.
Hi everyone, so my name is Susie Sapietz and I'm a research associate at the Tizard Centre, which is at the University of Kent. I recently completed a PhD on access to earlier support for families who've got a child with suspected or diagnosed neurodivergence, and I was brought into this group for two reasons. The first was because I have experience completing complex reviews as part of my PhD, and then the second because I'm autistic and have experience of mental health services, and I received my diagnosis of autism around 27.
Thank you. Hello, I'm Jenny Parker, and I am part of the Mental Health Policy Research Unit's Lived Experience Working Group, so that's how I got to be involved in this element of the work. In addition to that, I also work in Berkshire Healthcare, NHS Foundation Trust, so working from a lived experience perspective, but within their, I'll use it in quotes, personality disorder stream, where we do talk about neurodivergence quite a lot, so I'm really, really pleased about that. I'm also a lived experience researcher at City University of London, co-leading on a study investigating similarities and differences between personality disorder and autism in people socialised as female. So, you know, I'm quite passionate about this work because that's also been my own lived experience. Working on this study, I think, as well, has highlighted just how many people have been diagnosed with personality disorder, just to put it out there, when autism may be a far more fitting explanation, but that's obviously just partly my experience. So I thought it would be useful really just for this slide that we have up here to bring things to life and base it around my own experience, which illustrates how damaging and how invalidating it can be to be offered explanations and interventions, which were mentioned earlier a little bit around iatrogenic harm, that don't fit, and for services to overlook the possibility that I may have been autistic. So kind of if you're looking at the white boxes, that's my journey, and then I'm trying to relate it in the beige boxes to the study findings. So my own journey started with a long journey through various diagnoses, ineffective treatments, both medical and psychological. But just to add that I am not here to blame anyone. This is not about, we will work in healthcare to do the best that we can with what knowledge and training that we have. So it's really good to hear that training and increasing knowledge were elements about that. What also struck me about the review was that the search criteria, although ranging from 1994, most of the adaptations were within the last 10 years. So at the time of my earlier assessments, this probably wasn't even on consideration or on people's radars. But it does also make me think about how multiple diagnoses, non-response to treatment, may actually be a sign that someone is autistic, or even just to think about that. So my first and most important point really is for mental health services to increase awareness around possible autism. In my research at City, I've also come across people who've been misdiagnosed with personality disorder based on a crisis admission or obsessive compulsive disorder due to the need for things to be just so, because who wouldn't? So whilst 5 studies talked about increased awareness through clinician training and 3 on introducing the screening measures that we talked about earlier, a useful addition, in my opinion, would be to spend more time with someone so that you can see when masking actually starts to slip. And interestingly, one of the studies in this review did look at ADOS Module 4, and of the 25 people, I think it was, identified as autistic, something like a quarter were women with a pre-existing personality disorder diagnosis, which again was suggested by the authors that this may be overshadowed due to masking. In terms of assessment tools, again, thinking about language, thinking about communication, questions like, do you feel empty inside? Well, yes, I'm hungry, so I do. Okay, tick box for SCID 2. So it's good to see, therefore, that communication was the top adaptation, followed by the content and structure of interventions, because at least 2 of my own treatments attempted to change neuronal pathways in my brain, but my brain's fine. As I now know, it just didn't fit into the environment that I was in. So the environment, again, came out as important in the review. Things like ticking clocks in therapy rooms, loud voices outside when you're trying to do mindfulness, all of those things that really make it hard to keep focused, especially where there's a lack of structure in therapy settings. So that's something, again, that came up, perhaps in relation to psychodynamic approaches, and that was picked up by the study by Cooper and colleagues, I think, as less helpful than things that were more structured and more adaptable, like CBT. Accommodating individual differences, I don't know how I'm doing for time, so I'm just going to keep going, fits in with the manualised interventions. So, that kind of fitting the person, not the evidence-based intervention, I think is really, really important in here. Especially when those interventions were probably around, way before people were thinking about this. So what is it that we're missing here? And just to add on a positive note, that in March 2021, the good news was that I did finally have an autism diagnosis confirmed. I found a wonderful autistic therapist who used some of those visual things that you were talking about, actually. He had a little whiteboard and drew lots of the stuff out for me. Really, really helpful. So just thinking about that, how to accept my new autistic identity, giving guidance, just doing, all of the things that I was missing. So hopefully what I've said here can help to illustrate just how important this review actually is when working with autistic people, and how important it is to listen to us. So over to Susie.
Okay, so while the reviews identified several adapted approaches to improve mental health support for autistic people, I thought it would be important just to acknowledge that even getting to the point of accessing support isn't straightforward. Often people experience many different barriers. So I thought it'd be helpful to just quickly go over a couple of the systematic barriers. and also reflect on some of my personal experience. So firstly, referral pathways for mental health support are often complex, and there is a lack of information on these. So how do you even get a referral? Do you just tell your GP you're struggling, or do you need to explicitly ask for a referral to a specific service? It's really good that IAPT services also allow self-referral, yet IAPT have refused to offer me support twice. And also another thing that came up in the review is many professionals will have limited or sometimes even inappropriate knowledge of mental health and autism, which can make it difficult for them to know how to support you or who to refer you to. Secondly, as I'm sure you're aware, there's a significant underfunding of public services, which results in sort of limited capacity, long waiting lists, increasing thresholds for obtaining support, and reactive rather than proactive support. So I was under a mental health community team for around 2 years, and I never actually got any actual support from them, just assessment and monitoring calls. And in one phone call with a psychiatrist, they actually said that they didn't think I had any mental health problem, and that everything was actually just because I was autistic and it was due to autistic traits. But in the same call, they also said that they thought I had emotionally unstable personality disorder. And so I sort of challenged this and asked if I could speak with someone who had sort of more specific autism knowledge, to which they said they would refer me, but nothing ever happened despite chasing to this. And so sort of related to this is the lack of collaboration or coordination across services, which mean that a lot of people do fall through gaps. So the first time IAP refused to support me was actually when I was on an autism waiting list for the assessment. And they said that I couldn't be under both the mental health service and the autism assessment service, despite, the waiting list for the assessment being quite long. So actually, after getting through the assessment, I went back to IAPT and just got the exact same support I would have got regardless of having an autism diagnosis or not. So it seemed like there was no point really in waiting. And then lastly, there's a big reliance on short-term and often inappropriate, there's a focus on short-term, often talking therapies, and then discharge, and talking therapies might not always be suitable, especially without adjustments. And in my experience, talking therapy was only helpful to a certain extent, as it didn't sort of focus on trauma, which I think was the reason for my mental health difficulties. And so now I'm getting support from an autistic therapist who sort of understands autism because they are autistic, and they focus on trauma. But I think it's really unjust that people without the resources to find and sort of pay for this support won't be able to access it. I don't want to just focus on the bad stuff, so it was also really encouraging that there were several adaptations to improve support. So Jenny talked a little bit about some of the stuff around improving knowledge and identification of autism in mental health services. But here are some of the other sort of adaptations that have been helpful for me. So firstly, environmental adjustments that have helped are reducing background noise, including thinking about the time of day of sessions, as noise and vibration from buses can be really distracting and stressful. Things like using essential oils is really helpful, especially if dissociation in a session is likely. Encouraging helpful stimming to regulate during session, and also having an option for remote support where somebody might have a bit more control over the environment. Some communication accommodations that have been helpful for me are asking specific clear questions and prompts rather than open-ended questions. I can find it difficult with my memory, so knowing if there's going to be a specific question at the start of every session helps, so I can prepare in advance. Having something to focus on, like a worksheet, as it can sort of reduce eye contact and act as a visual reference to help someone open up. And then things like simple preferred language and providing written material. Regarding intervention content, taking it slow is really important to help build rapport and trust. Considering the role of autism both regarding difficulties and specific strategies to try, including emotion-focused strategies as well, as it can be difficult sometimes to identify and talk about emotions. And then lastly, regarding individual differences, people should find out about somebody's individual needs and preferences, which could be related to environment, communication and other areas. Asking about and also suggesting accommodations that might help. So don't just expect the person to know what will help them, because they might not be aware of it, so having suggestions helps. And also encouraging and incorporating individual interests. So me and my therapist often talk about cats. And then another adaptation that's really helpful is prompts and reminders for self-care during and after sessions, as it's really easy to sort of forget this. And most of these accommodations would be useful for, you know, any person, regardless of being autistic or not, so it's worth giving them a try. And now back over to Jenny.
Thank you. We've got about 30 seconds left, is that right? 1 minute? Okay, I shall talk really, really fast. So just to kind of reinforce the fact that, you know, co-produced research is essential. It really does increase the validity of data, especially when there are qualitative elements, which I'm a big fan of. I like words over numbers, although I know funders don't necessarily, so maybe mixed methods approaches. So whilst it's good to see that 7 out of the 30 studies did include autistic researchers, we obviously know there's quite a lot that didn't, so that's where the neurotypical bias came in helpful. And, you know, one example of that was useful when I read about the reduction of anxiety and restricted and repetitive behaviours in an 8-week CBT group, which was the study, I think, from 2021. So we all know that repetitive behaviours can help reduce anxiety in autistic people, but this finding could also be a feature of masking, which lessens when we find like-minded people, hence the kind of we get each other and, you know, kind of some of the other bits that are on the slide that I won't get around to covering just now. But it was also interesting that most people enjoyed this group in the feedback. They reported enjoying the group, which is not something I would have in my experience in the past. But this paper didn't appear to include an autistic researcher, so I wonder if that reduction in masking would have been thought about differently had it been. So just kind of thinking about that as well. Communication, just to go back, you know, that keeping it simple, ensuring people are fully informed, just lots of things around that. Having directions for things to get to venues today was really helpful just to reduce anxiety. How we interpret things might be slightly differently. I am out of time apparently, so I am going to stop now, but just to say that we are always learning, and I think that's really important for everybody that's part of this conference today. Thank you.